8 weeks or confirming that it is a viable pregnancy within the uterus or the womb. And we also know the importance of level 2 scan and a growth scan. But to tell us that we all forget 11 to 13 week scan, which is very much important. This we know that all the pregnancies are at a theoretical risk of aneuploidy or a chromosomal abnormality. FMF or the Fetal Medicine Foundation UK has stated that about 70% of the pregnancies have trisomy 21 or the chromosomal abnormality in the women who have aged less than 35 years, and only 30% in those who are about 35 years. So it is very much important even for the lower age group women to be screened for trisomies. So that is why we have a universal screening approach which is carried out at the gestational age of 11 to 13 weeks. The Fetal Medicine Foundation UK has now inverted the pyramid of prenatal care, and it is now more important to carry out the scan between 11 to 13 weeks or say 12 weeks, waking up late in the pregnancy at say 37 to 41 weeks. So we can divide those who are high risk and those who are low risk, and accordingly shift the prenatal care from the routine to disease specific approach in the high risk group and reduce the number of visits of the antenatal care in low risk groups. Why is it important that we must all go for 11 to 13 weeks? Because it's important to date the pregnancy, which is more specific at this time, to determine the chorionicity, which is very much important for the twin pregnancy, screen for the chromosomal abnormalities, for detection of the structural abnormalities, screening for preeclampsia, hypertension in the mother, or for fetal growth restriction, which is baby growing smaller than usual, and screening for preterm labor or premature labor. So first, as we saw, dating of the pregnancy. The CRM during the time of 11 to 13 weeks is around 45 to 84 mm. If it is more or less and the mother is not sure of her dates, we can redate the pregnancy and continue with the new dates in the later half of the pregnancy. But if we find that it is an early fetal growth restriction, it points to a very serious condition known as trisomy 18 or triploidy. So it is very much important for us to date the pregnancy by the scan. Another, as we told, it is very much important for the twin pregnancies to determine the chorionicity, whether it is a lambda sign or a T sign, depending upon which we can say it is a non-identical twin pregnancy, or the twins are identical, or we can say that they are dichorionic diamniotic twins, or monochorionic monoamniotic or dichorionic monoamniotic twins, because the complications in the identical and non-identical twins are completely different. So we need to follow up them differently. The other most important thing which must be highlighted is that the chorionicity can be best done before 14 weeks. So here again, the cutoff makes us very much important. The third most important thing for why we do the scan is screening for chromosomal abnormalities. We know that all of us have 23 pairs of chromosomes. They are arranged in a pair, as we can see here. But if instead of a pair, we have 3 chromosomes in a particular set of a number of chromosomes, like here it is in 21, here it is 18, here it is 13, then we tell that condition to be trisomy. And for the most common trisomies, 21, 13 and 18, we perform the screening at 11 to 13 weeks. What is screening? So in a given population, we apply the screening test or a particular test to whole of the population, and then we sort the population into high risk group and low risk group. The one which is high risk can be then subjected to a diagnostic test, which we'll see further. The one which is low risk can go for the routine antenatal care. So this will be cost effective as well as help us in deciding who need extra care. Those which are coming in the high risk category, they do not always are certainly diagnosed as positive, but they can be, with the help of diagnostic test, confirmed that they are having or can be ruled out of having a particular condition. So diagnostic test can be applied to a high risk group, and it tells us for 100% surety whether the condition is present or is not present. In our case, the diagnostic test will be an amniocentesis, that drawing out of water around the baby from the womb, or to draw the bits and pieces of placenta. He was Langdon Down, after whom the Down syndrome is named, that is trisomy 21. And ultrasonographically, biochemically, by mother's blood, and by the age factors and the other maternal history, we derive patient-specific risk for a particular pregnancy, whether the mother is high risk or low risk of getting a baby with trisomy 21. So the markers sonologically which we use are nasal bone, nasal nuchal translucency, ductus venosus with regurgitation. Those which are drawn from the maternal blood are papae and beta HCG. The nuchal translucency is the fluid behind the neck of the baby in the neutral position with adequate magnification and perfect measurement by on-to-on placement of calipers. Then this is plotted on the charts, and when we find that based on the CRL whether the nuchal translucency is increased or is within the normal range. If it is increased, it can be because of various reasons, because of the cardiac defects, venous congestion of the head and neck, altered composition of the extracellular matrix, failure of lymphatic drainage, fetal anemia, fetal hypoproteinemia, and fetal infection. This is a very good chart for counseling. It states that at a particular level of entity and the particular level of the gestational age, what is the chance of getting a normal baby versus what is the chance of getting a baby with abnormal karyotype, one which would die in utero and one which would be having major structural defects. So for example, at a particular CRL, the nuchal translucency is around 3.5 or 3 mm. The risk of getting a child with abnormal chromosomes is 3.5%, whereas the one of getting a dead baby inside the womb is 10%. One with having the major structural abnormalities is 2.5%, whereas there is still 90% chance that the baby would be normal. So for this, whether the baby actually has an abnormal karyotype or not, we must go for the diagnostic test, that's a needle test. So once we have a high-risk baby, we must go for the diagnostic test, that's the chorionic villus sampling at 11 to 13 weeks, which will be followed by an early anomaly scan. And if the normal base of karyotype is normal, that's the normal chromosomal pattern, we must go for echocardiography and an early scan at 14 to 16 weeks, followed by the routine anomaly scan. In any case of chromosomal defect or a major abnormality, the parents must be counseled and the decision of the termination should be taken in concern with the parents. Another marker which is very specific is the nasal bone. So we must all see the three lines representing the tip of the nasal bone, the skin over the nose and the nasal bone itself. So the skin over the nose and the nasal bone itself represents an equal to sign. This must be seen for the marking the normal nasal bone. In any cases when we cannot see the underlying nasal bone, or we can see as the echogenicity same as that of the overlying skin, we can mark it as inconclusive. If this is not seen, we can mark it as absent or hyperplastic. This will be found in 50% of the Down syndrome cases, 50% of trisomy 18 and 30% of trisomy 13, but it can also be present in the normal population, especially in Caucasians, Afro-Caribbeans and 1.4% of the other ethnicity, but normal. Another marker is ductus venosus blood flow. Ductus venosus is a small vessel about 2 mm diameter which connects which shuns the blood from the umbilical vein to the inferior vena cava in the fetal life. The abnormal ductus venosus flow is found in 80% of chromosomally abnormal fetus and 5% of euploid fetuses. In 65% of the fetuses with trisomy 21, in 55% with trisomy 18, and 55% of trisomy fetuses, we can find that the E wave is reversed. Apart from the chromosomal abnormalities, it can also be found in the fetuses with the cardiac defects, those who are at the high risk of intrauterine fetal death or missed miscarriages. So we must go for mean uterine artery PI, which should not be more than 6 months, or we must order a growth at 28 weeks and a close surveillance then after. The fourth marker which we integrate in the combined screening test for trisomy 21 is tricuspid regurgitation. So whenever we place our calipers in the four-chamber view at 11 to 13 weeks on the right side of the heart and take three parallel views for the tricuspid flow, this is the normal flow, the two upward flowing waves and the third downward flowing wave, which is not more than the velocity of 60 centimeters. If it is at all more than the velocity of 60 centimeters per second, it is marked as regurgitation. The fifth marker is the fetal heart rate, which we can see for ourselves that in trisomy 21 it's usually the normal, but there can be 15% of cases where you have more than 95th centile. In trisomy 18 it's usually less than the 5th centile, whereas in 13 it's far way above 95th centile. Coming to the diagnostic tests which give us 100% accuracy, they are chorionic villus sampling, that is taking the bits of the placenta. The chorion villus is the placenta. And this is done before 14 weeks. After 16 weeks, when there is a fusion of the membranes, we can perform amniocentesis, which is taking the fluid around the baby in the womb. This all is done under ultrasound guidance, but the only disadvantage is that there is a risk of miscarriage. Though the absolute number of miscarriage is reduced from 1 to 0.1% as the procedure related risk, but still this risk holds. So for each and every patient there has to be individualization in terms of risk benefit ratio, the risk of getting a Down syndrome baby vis-a-vis the risk of getting miscarriage from this needle test. The other important part of 11 to 13 week scan is a structural abnormality survey. So we need to survey from head to toe that the fetus is absolutely normal for what we can see at this gestational age. So starting from the head, we can see that the skull bone is properly formed. We see a butterfly-shaped choroid plexus with no cystic structures in it, that is, there is no presence of choroid plexus cyst. We see for both the eyeballs. We see for the lenses within them, we see for the maxilla, the upper jaw, the continuity of that, so that we know that there is no cleft lip or cleft palate. We can see the lip around it also very well. We need to have the four-chamber view of the heart and to see the concordant flow in the ductal and the aortic arch as the V sign, and that rules out the AVSD. We need to see for the limbs. We need to actually count for all the 5 fingers in the hands and see the footprint. We need to see that the stomach bubble same side as the four-chamber heart, so there is no possibility of situs inversus. We need to see that the umbilical cord entry is normal and that there is no abdominal wall defects, no gastroschisis, no exomphalus. And we need to see that there are 2 umbilical arteries around the properly filled bladder, so that the bladder is not abnormally large, it is neither absent. Then in the longitudinal section, we need to see that there is no hepatomegaly, the diaphragmatic continuity is normal, and in the prone position we need to see that the spine looks absolutely normal, but the skin overlying is still normal. And then of course we can aid the 4D or the 3D scan to visualize the other structures. So it was said that there are always detectable anomalies which include acrania or exancephaly, that is absence of the skull bone and pouting out of the brain, which we can see here. We can also see with the holoprosencephaly that there is an abnormal division of the rim, or we can see for exomphalus, that's the protrusion of the intestines, but it's covered by a membrane, or we can see the gastroschisis where there are free floating loops and the amniotic fluid, or we can see megacystis. So this usually, and this should be detectable at 11 to 13 weeks. There are a few more anomalies which can be detected, which will talk later. Consider the mother to be equally important, and so we also think that at this time 11 to 13 weeks we can also try and predict certain abnormalities which may take in the mother itself. So one of them is the high blood pressure in the mother, which develops usually after 20 weeks, termed as preeclampsia. This may be associated with the proteins in the urine, convulsions if it is severe. This can be predicted by uterine artery Dopplers, which we see here, and the blood flow here. If it is more than 1.6 moms, we can mark it as a high risk and we can follow up it in a particular way. Along with that, we can combine mean arterial blood pressure, PAP-A, and PFLGF. These two are derived from the maternal blood. This is simply the blood pressure which is taken in both the arms of the mother, and then we calculate the mean arterial blood pressure. There has been a study which says that the specificity of the first trimester uterine artery Dopplers is 91 to 96%, which is very good. And this also helps that we may start aspirin, low dose aspirin before 16 weeks. Because after 16 weeks, it's of no use to start aspirin. So predicting preeclampsia by 11 to 14 week scan is very much important invention. The other part is cervical length measurement by a transvaginal scan at the same time, so that we can know whether it is of the normal length, as we can see here, or whether there is funneling and shortening of the cervix, in which case we may need to follow the woman 2 weekly, or we may need to put a history or ultrasound indicated sarcoplasm. There's the FMF software. The Fetal Medicine Foundation UK provides a software by which we need to enter the maternal history, the number of births or miscarriages, second trimester miscarriages, and the cervical length, and it gives us the risk of preterm delivery. So the reporting would be in this format, that we enter everything. There's the FMF software for the first trimester, which includes the CRL, the fetal heart rate, the nuchal translucency, the intracranial translucency, the ductus venosus blood flow, absence or presence of nasal bone, the tricuspid regurgitation, and then it integrates into the form of background risk and the adjusted risk. So the background risk, we all know, that is dependent upon the age of the mother, and then we modify it by the adjusted risk, which in this case, as we can see, it's 1 in 1500 by the age of the mother, and it's decreased to 1 in 2000 by the combined screening test. As we already talked, that the risk of preterm delivery will also be predicted by the software. It would be, like in this case, it is only 4, but it is still below our cutoff of 1 in 10. Similarly, we can also get the risk of fetal growth restriction, that is the baby growing smaller than usual, and the risk of mother getting high blood pressure before 34 weeks. This is very much important in knowing that efficacy of the scan or the combined screening test which we are performing at 11 to 13 weeks, which we can see for combining meta-age, efficacy is only 80%, which increases to 95% when we combine the maternal blood markers, and it even increases to 96% when we combine all the 5 markers, like blood and the age. We need to do the scan between 11 to 13 plus 6 weeks. When we do a scan between the gestational age, we must find that the CRL would be between 45 to 84 mm, and when the CRL is between those two ranges, only then we can see for the rest of the 5 markers which we were talking. The reason for selecting the lower limit as 11 is associated with certain detectable anomalies after 11 weeks. That is, one is the head is completely formed, anencephaly can be very well detected after 11 weeks. Another is the physiological of intestines, which can positive result for examples is already disappeared at this gestational age. Another is that sampling, if it is because of the high positivity, it is set as 13 plus 6 because in women who are affected, the affected fetus appear to have the nuchal translucency, which is more detectable in this Gestational age. After this gestational age, the fetus becomes more vertical and it is very difficult to obtain the image of the good nuclear translucency. If the diagnostic test comes to be positive and the woman opts to terminate the pregnancy, it is obviously better to give her an option of first trimester termination rather than. Finally, we have been hearing that there is something known as NIPT or NIFT or cell-free fetal DNA or cfDNA in the market in vogue. But we must know that the nuclear translucency scan or the 11 to 13 week scan does not should not be ruled out when we go for cfDNA. So cfDNA does not overshadow or does not supervene the importance of the scan, because the structural abnormalities, certain markers, the preeclampsia screening, the cervical screening will not be overshadowed by use of cfDNA. Also, there are certain disadvantages of cfDNA like mosaicism and only 90% efficacy. So we should not forget to do an 11 to 13 scan. And finally, it's our responsibility that we can counsel the parents, we can individualize, we can discuss the decision and help them to take a decision. It should be rather than arbitrarily defining them as high risk and low risk. So we're always there them to help rather than to decide for them. Thank you.